Anna is a divorced 61-year-old white woman. She is an ex-smoker with a BMI of 29. She presents with symptoms of occasional urinary leakage and strong urgency to urinate. She tells you she wears a panty liner and carries absorbent pads and panties. She reports feeling young and healthy overall. She is pre-diabetic and takes a statin. She's not sexually active and does not use topical estrogen. She tells you, "I don't believe in taking a lot of medicines." You recognize the signs of overactive bladder, or OAB. You know that overactive bladder is a symptom complex comprised of urinary urgency, with or without urge incontinence, usually accompanied by urinary frequency of more than 7 times in 24 hours, and nocturia. Urinary urgency is the hallmark sign of overactive bladder, or OAB. Patients with OAB do not complain of pain or dysuria. You know that approximately 1/4 of U.S. adults 18 to 70 have OAB, and that OAB is more prevalent among women than among men. Women have greater urge incontinence. You know that urinary tract infections, anxiety and depression, falls and fractures, and skin irritations are seen more frequently in patients with OAB. Falls and fractures are a concern for elderly patients who are particularly vulnerable to the risk of falling due to the need to hurry to the toilet before a leak occurs. Urinary incontinence increases the risk of falls among those ages 65 and older by 45%, and data from the Centers for Disease Control and Prevention, or CDC, indicate that 1 in 5 falls to those ages 65 and older result in a fracture or head injury. You remember that the research clearly indicates a negative impact of OAB symptoms on psychosocial functioning and quality of life. In one study, 65% of individuals with OAB reported impairments to overall quality of life. Those with incontinence report more difficulties than those without. You know that despite the widespread prevalence of OAB and its impact, many patients remain undiagnosed and undertreated. On average, patients wait more than 3 years before seeking treatment for OAB symptoms from a healthcare provider. You know that in an overactive bladder, the detrusor muscle, the muscle that forms a layer of the wall of the bladder, contracts before the bladder is full. You also know that the 3 major types of urinary incontinence are: stress incontinence occurs during sudden increases in intra-abdominal pressure, such as coughing or running; urge incontinence, where involuntary urinary leakage is accompanied by urgency; and mixed incontinence, which is a combination of the two. You know that the bladder has a limited way of expressing its own pathology, so those few symptoms of overactive bladder can actually have a number of different underlying causes. Most are related to the lower urinary tract, and some are due to more generalized medical conditions. You are also aware that neurological disorders, including multiple sclerosis, stroke, Parkinson's disease, spinal cord injury, and spina bifida may cause OAB. You begin Anna's evaluation with a focused history and exam. You do a urinalysis. A urine culture may be needed to completely exclude the presence of clinically significant bacteriuria in some patients with irritating voiding symptoms. Bacterial UTI should be treated with culture-specific antibiotics. You know that a focused questionnaire can be used to evaluate the impact of symptoms on the quality of life and elicit information about how the patient is currently managing symptoms. You ask Anna, "How often do you pass urine during the day? During the night, how many times do you get up to urinate? Do you have to rush to the toilet to urinate? Does urine leak before you can get to the toilet?" As a follow-up to each question, you ask her to frame her responses on a scale of 0 to 10, with 0 being no bother and 10 being great bother. You perform a physical examination to evaluate Anna's overall physical health: neurologic, urologic, gynecologic, and neurourologic health. You perform a vaginal examination to assess Anna's perineal sensation and reflexes, check for vaginitis, pelvic organ prolapse, masses, tenderness, and urethral diverticulum. You know that the following cases should be referred to a specialist: hematuria, diagnosis unclear, obstruction voiding symptoms, pelvic organ prolapse, no response to medications, elevated post-void residual, prior pelvic surgery, bladder pain, neurologic disease. You know that the bladder diary is a very useful part of the assessment of OAB. The information collected helps the clinician plan the intervention. It also helps increase patient awareness of voiding habits and may help patients recognize activities that trigger incontinence. Patients can keep a bladder diary for 3 to 7 days. They record the time and amount of fluid intake, urinary output, and any other symptoms. You know that current guidelines recommend patient education and behavioral therapy focused on bladder retraining for OAB symptoms, with or without incontinence, as Tier 1 treatment. You know that primary care providers can enhance patient bladder health literacy to provide the foundation for behavioral and medication interventions, in which the patient takes an active role. You know that you can increase patient adherence by setting realistic patient expectations. You know that provider support can impact the success of behavioral interventions. The key point is that the clinicians invest the time to educate patients about their condition and counsel them on management strategies. Nurses, health educators, and caregivers for the elderly can be trained to support and encourage patients in implementation. You recall that bladder retraining is the cornerstone of behavioral intervention. The bladder diary is used to identify behavioral patterns and develop treatment strategies. Bladder retraining is effective in 40 to 90% of patients. Significant changes can be seen in approximately 6 weeks. Frequency of incontinence can be reduced 50 to 80%. You know that the type of amount of fluid intake may need to be adjusted based on the bladder diary. Most patients do not realize that the body cannot manufacture fluid and that all the excreted urine is derived from fluid intake. In some patients, this education is all that is needed. If that is not enough, the patient is instructed to increase the intervoiding interval gradually by 5 to 30-minute intervals based on the voiding pattern. You know that bladder retraining helps patients identify patterns and take control of their symptoms. Encourage patients to avoid a rush to the toilet. Patients can learn to recognize trigger situations. Some patterns appear to be Pavlovian reflexes. For example, urgency can be precipitated for some patients by reaching the garage door or rising from standing to sitting. Non-Pavlovian reflexes are triggers such as bladder volume or trigger by certain foods or beverages. Some patients have no symptoms when they are preoccupied, and others have no pattern at all. Patients can practice easy, focused breathing. Patients should be taught to take control of urgency by using the knack technique. When urgency comes on, stop and stay still. Concentrate on suppressing the urge. Contract pelvic muscles quickly several times. Wait until the urge subsides. Then walk to the bathroom at a normal pace. You know that bladder retaining and pelvic floor muscle exercises called Kegels can be used together to increase the likelihood of staying dry. Kegels strengthen the muscles that support the bladder, urethra, uterus, and rectum. They are primarily used in patients with stress incontinence, but may be beneficial in patients with overactive bladder and urge incontinence. A Cochrane analysis confirmed general efficacy in reducing incontinence, finding that 56.1% of women who performed Kegels were cured versus 6% of controls. Patients can be referred to a physical therapist or nurse practitioner for a more intensive program incorporating biofeedback. You know that no single behavioral therapy is most efficacious. You explain normal and abnormal bladder function and the benefits and risks of treatment alternatives. You tell Anna that she may find significant relief of her symptoms through what's called bladder retraining. You tell her that 50 to 75% of patients experience a substantial reduction in symptoms, and up to 15% of patients experience an end to their OAB symptoms. You also tell Anna that bladder retraining will take time and effort on her part. You discuss lifestyle changes with her. You recommend selectively decreasing fluid intake, perhaps before bed, to decrease nighttime urination. You inform her that decreased fluid increases urine concentration, and that may contribute to OAB symptoms, so she needs to find the right balance. Avoiding bladder irritants such as alcohol and spicy and acidic foods, and keeping caffeine consumption below 400 milligrams per day. That's roughly the amount of caffeine in 4 cups of brewed coffee, 10 cans of cola, or 2 energy shot drinks. Also, carbonated drinks and artificial sweeteners are bladder irritants for some women. Avoiding constipation. Managing her weight is also important. She may also find that increasing physical exercise and trying mindfulness-based education may help relieve OAB symptoms. You know it's also important to address other health issues, particularly those that may also impact bladder functioning. You know that when treatment goals are not met after an appropriate duration, pharmacotherapy is recommended as Tier 2. Behavioral therapy may be combined with drug therapy when treatment goals have not been met by behavioral therapy alone. When treatment fails and further treatment is in the patient's best interest, reassess and refer to a specialist. You know that OAB is a symptom complex that is generally not life-threatening. After assessment to rule out conditions needing treatment, patients and caregivers may choose no treatment. You also know that topical estrogen may be an option down the line, but that oral estrogen may make leaking worse. You discuss menopause with AMA. You tell her that declining estrogen can cause something called genitourinary syndrome of menopause, or GSM, which can trigger symptoms of OAB. You tell her that if she continues to experience OAB after bladder retraining, you can discuss the use of topical estrogen cream at your next visit. You tell Anna that there are no new findings on her physical exam. You counsel her to take bathroom breaks when she feels the urge to urinate rather than waiting. You ask Anna if she has any further questions. She doesn't. You ask Anna to schedule a follow-up visit in 6 to 8 weeks so you can assess her progress and wish her luck with her bladder retraining.